Greetings and welcome to this video on nitrofurantoin, the urinary specific antibiotic that targets specifically the urinary tract organisms and not even for the pyelonephritis, only for cystitis. So in this video, we'll discuss about the mechanisms, indications, toxicity, and the dosing guidelines from a physician's and critical care practical approach. So if you're new to this channel, do subscribe. This is Medicine Beyond Harrison's. Let's get started. So the old but highly relevant oral urinary antiseptic is still the nitrofurantoin. It's primarily a cystitis only drug, unique niche because it's having a very high urinary concentration, low systemic levels, and retained activity versus resistant drugs. So it is not a weak antibiotic; it is a highly targeted urinary antibiotic. Remember this one thing. So it enters the bacterial cell reduced by flavoproteins. There is reactive metabolites produced, which damages the DNA, damages the ribosomes, and disrupts almost all enzymes inside the bacteria. So it is a bactericidal drug plus a very low resistance drug that targets all these three DNA, ribosomes, and enzymes. So that the bacteria almost cannot produce an resistance against nitrofurantoin. So it is a 12 milligram per mole molecular weight drug with high hydrophilic components with favors renal excretion over tissue penetration. So mainly excreted through the renal route to reach the urinary bladder. Almost 40 to 80% is absorbed orally. If you take it with food, its absorption is increased, and magnesium antacids reduce its absorption. So it's almost 60% protein bound with volume of distribution of 0.6 to 0.8 liters per kg, which is almost okay. So peak plasma concentration is less than 2 micrograms per ml. So nitrofurantoin does distribute beyond urine. So what plasma levels are too low to treat any systemic infection. So no meaningful systemic antibacterial. So only in the urine it reaches adequate minimum inhibitory concentration and it have its no effect in the systemic infections. So renal handling majority is excreted unchanged in urine. There is active tubular secretion of nitrofurantoin as well, and there is tubular reabsorption also. So metabolism, it is minimal hepatic metabolism. pH alkalotic urine leads to increased reabsorption and decreased efficacy. So half-life is 20 to 40 minutes plasma half-life. So there is a need for frequent dosing, twice or thrice daily, and poor systemic activity. Urinary concentration, adequate urine concentration achieved at 50 to 300 micrograms per ml. Baseline minimum susceptibility breakpoint is 64 micrograms per ml. Nitrofurantoin can be clinically effective even if lab reports say intermediate sensitivity. So this is the reason because it has high urinary concentration. Spectrum it is active against these specific organisms, which are these are usually often liquid Enterococcus fecalis, Enterococcus faecium, including vancomycin resistant Enterococci, but only for cystitis and not for pyelonephritis. Against for Staphylococcus saprophyticus and even for against some Staphylococcus aureus species. Gram negative, most of the E. coli, Citrobacter, Klebsiella, Enterobacter, all these Enterobacteriaceae are susceptible. Even the ESBL and AMC producers in the urine, if it is just cystitis, it is susceptible. These are the organisms that is not covered by nitrofurantoin. So if you suspect these organisms, there's no point in giving a nitrofurantoin. For PPS, for Morganella species, Providentia, for Pseudomonas, mainly for Pseudomonas, ciprofloxacin or other anti-pseudomonal penicillins are meropenem, imipenem or preferred rather than giving this nitrofurantoin. Serratia species, Xenotropomonas multipla, Acinetobacter species, and CRE, carbapenem resistance intercocci. In all these Enterobacteriaceae, all these species, nitrofurantoinos are not active. So these are the very important gap that you need to understand. More than the species that are sensitive, you have to know the species that are resistant to nitrofurantoin. It is currently it is used in uncomplicated cystitis, catheter-associated bacteriuria. So step-down oral therapy, one sensitivity is known. So no, when there is no pyelonephritis, no sepsis, no bacteremia, only in these cases you can use nitrofurantoin. So if there is pyelonephritis, there is no point in using nitrofurantoin. When there is sepsis, no point in using nitrofurantoin. When there is bacteremia, there is no point in using nitrofurantoin. It never treats pyelonephritis, urosepsis, bacteremia, perinephric abscess as an ICU source of sepsis. So treating by nitrofurantoin treats only the urine, not the kidney or the blood. So in an ICU setup, you can use it as a step-down oral therapy only if the confirmed is sensitive isolate plus bladder infection only. Preferred formulation is monohydrate or macrocrystal formulation, which is given 100 milligram twice daily. Other formulations are macrocrystals with the macrodantin and piradantin composition, which is given Q6 hourly. Increased frequency of dosage is required. Either 50 to 100 milligram it is available. So most preferred is the macrocrystal formulation of monohydrate or also macrobid, which is 100 milligram given twice daily. So traditionally, it is contraindicated if GFR is less than 60, but data suggests that even cure rates is maintained even if GFR is less than 30. So there is no GFR leads to accumulation and increased risk of pneumonitis, increased risk of liver injury. So try to avoid nitrofurantoin if the GFR is less than 30, that is CKD stage 4. Hematological risk, hemolytic anemia, especially in G6PD deficiency. Don't try to give nitrofurantoin, avoid nitrofurantoin. So oral magnesium decreases its absorption. So these are drug and drug interactions. And excretion, protein acid decreases renal excretion, decreases urinary concentration, increases toxicity risk. Common adverse effects are present as for all other drugs: vomiting, diarrhea, anorexia, and nausea. Serious long-term side effects are the pneumonitis mainly. When you give it for weeks, for example, prophylaxis of urinary tract infection is given every day a single dose. It can cause pneumonitis. Chronic intake can cause ILD for months to years if it taken. Neurologically, it can cause peripheral neuropathy in pulmonary usage. In hepatic chronic hepatitis and rarely hepatic failure. It can also cause rarely pancreatitis and lactic acidosis. So duration, short courses are generally safe, 5 to 7 days. Long-term prophylaxis, higher risk of neuropathy, hepatitis, and pulmonary toxicity is there. So practical prescribing checklist. So when there is all these criteria are taught are fulfilled, then give nitrofurantoin. If it is only cystitis, you can no fever, or no flank pain, no sepsis. You can GFR is more than 30, no G6PD deficiency, organism likely sensitive, not the organisms that are non-sensitive as we discussed, not pregnant at term. So all these cases should be fulfilled before you give a nitrofurantoin. The nitrofurantoin pregnancy, early and mid pregnancy, that is first and second trimester, you can give. Often generally used for safe and considered safe for asymptomatic bacteriuria. Near term, it can cause neonatal hemolysis, so avoid it. So why resistance is low? Because of multiple intracellular targets such as having affecting the DNA, enzymes, and the ribosomes. Requires multiple simultaneous mutations to develop resistance. So there is excellent longevity and stewardship for nitrofurantoin. It is one final take-home summary is that it is highly targeted urinary antibiotic, best for uncomplicated status. It is also stewardship friendly, decreased resistance development. And the bad things are ineffective for systemic infections. Avoid if GFR is less than 30. Watch for lung and liver toxicity in long courses. This nitrofurantoin itself can cause chronic hepatitis and chronic liver disease and liver fibrosis, lung pneumonitis, so peripheral neuropathy. All these things should be considered before giving a nitrofurantoin. But it is a very good antibiotic if used appropriately. So we learned a lot about this nitrofurantoin drug. We'll discuss more about this antibiotic series in the upcoming videos. If you like this video, do like and subscribe and share it with your friends. Thank you for watching.